We got 4 people now.
Yeah.
This is great.
So I welcome you all, and let's start with introductions. I think most of us know each other, but let's try it anyway. Here at Wayside, we have me, Rebecca Buller, and
Jesse Everts, Vice President of Clinical Programs.
And James is also here, our IT manager.
Perfect.
Let's go to Roxanne. Oh, I'm sorry.
Hi. That's okay. I'm Roxanne Kibben, and I'm the project coordinator for Echo at Hennepin Healthcare. And I just want to make a shout out for your presentation at the March conference and informing people about ours. And I'm glad that we have the opportunity, at least I can be on this one. Mm-hmm. We unfortunately do have a overlap coming soon, but I'm glad to be here. Thank you.
Thank you. Who is on the phone with us?
Hello.
Hello.
Oh, this is Deb Morrison with HSI Victim Assistance Program.
Yes, Deb, we were just talking about you, and we were going to help you find a way to get in so that we can see you, but it didn't happen just yet. So next time.
Okay, sounds great.
And then Alejandro, please introduce yourself.
Yeah, hi. So my name is Alejandro Diaz, and I'm a social worker. I do some social work and I do some clinical work. And I'm currently working with the main thing I do. I work with the Alzheimer's Association, and I do I'm a program manager, and I do the education and the outreach with the Latino community, mainly in the inner cities. Also, I do some groups in the evenings. I do some domestic abuse groups. I work with the guys that they're court order groups, and some chemical dependency groups, more like DUI groups. So, and I have done these groups within the St. Paul, Minneapolis, for the last 6-7 years. And I work mainly. I do like right now. I'm currently doing one in Spanish and one in English, and I'll explain a little bit more what it is towards the end. But,
great.
I want to share, Rebecca asked me to share some of the information about the cultural consultant group that we have. And I'm going to go right into the, and I know there's only a few people here, so we don't have to wait till the end to ask questions. I think it's better to do a little more interactive. I know I only have 20 minutes, so we don't have a lot of time. So just for the sake of time, just ask questions. And I want to share a little bit about the cultural consultant group. So here it goes. So as you can see, a cultural consultant group, it was put together by Nancy, and she was with the Minnesota Board on Aging until this week. But I'm glad she put this group together, and it's still current and it's still alive. So this is a group of people. We have people from the Somali community, people from the Hmong community, people from the Latino community, from the LGBTQ community. And they currently working with the community doing different things. Like in my case, I work with a lot of people with dementia, Alzheimer's, and also I do the chemical dependency domestic abuse groups. So but everybody is an expert in their community. And although this started as a group that works mainly with dementia and Alzheimer's, this is people that works in the other areas like me. I do other things besides that. So we were talking about the business side. Some of the help you get with the programs and services, but the main thing is identifying the services and the gaps in the community that they're working with. For example, I work with a Latino community. I was in a federally qualified clinic this morning doing some education and outreach, and then the particular group that I work with, they use mainly the federally qualified clinics, and the reason being is not only because of the cost of healthcare, but because about 42% of the people who goes to the clinic, they're uninsured people. And by being uninsured, there's people with no social security numbers, so therefore they can't access the insurance. Even going to the county building and applying for welfare, that's not going to happen because they can't. So they go to the federally qualified clinics, and they have a scale pay, which means they pay according to how much money they earn, like $5, $10, $15, no more than $20. So there's one example of that. Mission under the cultural insight and wisdom, like having the experience working with each group. Like I said, I work mainly with the Latino community. So when I work with them, I know what kind of programs and what kind of access to what programs they have, and the insight of the people that I know in the community that will help you with programs that are not related to government programs, but programs that are being provided for free, either by a church or anybody else, community-based organizations that will help you. They will serve the people with no insurance. And that comes to the equity part. So we're trying to equalize that to with somebody like you and I, if you have an issue, with you need to go to the doctor, you make an appointment, you go to the doctor, you have access to healthcare. Well, because there is no access to any clinic, so we're trying to equalize that with using those clinics that we know we serve the particular population. And the thing is, we go in there in, for example, the mentioned Alzheimer's, we had a grant that went and did some training with the doctors in the clinic to be able to do the assessment and the diagnosis for the people at the federally qualified clinics, because they couldn't refer people to a neurologist or to a specialist because they can't afford that. So there was, an example how to trying to equalize those services in there. And the goals is to like ethnically and culturally diverse people. One thing with that is the tools. A lot of the tools, like the assessment tools that are being used in the clinics, the tools is mainly geared for the general population. And this is nothing to do even with the languages. Like when I use the assessment tools to do the cognitive test for people to see if there's any signs or any, when the people have memory issues and if any signs of dementia or Alzheimer's. A lot of those tools are geared for someone who speaks English, and mostly white. So, and it's not so much of the language and knowing the background and what the person grew up, because a lot of people, for example, they come from rural southern Mexico. And then even if I translate it to exactly what it says word by word, a lot of those things don't make sense. It doesn't mean that the person has memory issues or don't or can function well. So you use the other ones that have more of like imaging, so to truly test the memory, of the person. So it's more. There's some of the tools that are more of how do you say, culturally appropriate for everybody, and they're to get a true assessment done. Let me see if I can. Let me use this slide I'm using. Sorry. Can you see the next slide in there? No, I didn't change it in my 1 second.
Yes, we can.
Give me 1 second. Oh, okay. Never mind. There you go. Okay, there you go. So what's a cultural consultant? So like I said, is a cultural consultant is a community leader with knowledge in their culture. And there's usually people that already works with a particular culture. And then they provide some of the following services like focus groups. I do currently do focus groups in one of the clinics where we do support groups for the caregivers and the families with the people with Alzheimer's, dementia, and we do it in Spanish. Need assessments, like I said, we do the assessments that are particular applied to their culture, not only in their language, but for the particular culture. Community engagement, we do we go into your clinic or community-based organization, and we do outreach and engagement. And for example, about a couple months ago, I went into one of the clinics and we did a dementia and Alzheimer's education for a whole day. And we invited the other community-based organizations, has services for the particular community. This was for the Spanish community. So we invited the PCA services, the homemaking services, the adult daycare services, but the people they did work and they had the services in Spanish for the particular community. Education and training. I do, for example, the Alzheimer's, I do the education and training not only for the families, but also for the clinics. So we go in the clinics and we do the training. We provide the CEUs for free for the staff in the clinic, and in the gears is specifically geared to that particular community. In this case, the Spanish community. Let's see the next one. So as you know, Minnesota population is obviously getting more diverse. And the reason being is when you bring a culture consultant to your clinic, right? Like, for example, the work that I was doing with the Alzheimer's Association, we were having like less than 1% of the people coming to the association because of, where it was located and because there was no outreach in the inner cities with the particular groups. For my case, I did a lot of outreach with the Spanish and the Hmong community. So you truly have to go where the people are, where their services are, and where their people are going to. So that's when I engaged the clinics that serve mostly Latino and Hmong community. I went to the community-based organizations. Like this morning, I was in the Mexican consulate giving a talk about the 10 signs, what we'll talk about in a second, about the 10 signs of Alzheimer's and dementia and what that means. But you're right there where the people is. And one thing is, because of a lot of the political situation right now, when you deal with the people, you have to be very specific and, let them know this is a free service. This is nothing to do with the government, and this is not something we're billing for, because people will be really hesitant to share information with you if you ask for their name, their last name, that they have a social security number, and now they have insurance. So gaining the trust of the community, and then is a way to get in. Otherwise, people will usually be hesitant and will tend not to go to or get services just to being afraid of, if you will share their information or this is linked with any government programs. You have any questions? Okay.
Not yet.
Sorry.
Not yet.
Not yet.
Okay, sorry. I don't want to go on and on.
No, thank you.
Yeah. So, related to the dementia and Alzheimer's, some of the services that we do, they're mostly to do with the caregivers, not only with the person with a diagnosis, with the caregivers. So we talk about a lot of the 10 signs of dementia and Alzheimer's, and these have to be significant issues enough to disrupt daily life. Like, for example, this morning when I was going to the clinic, I got my papers, I got my information, I got the materials that I needed, I got my coffee. So I walk up to my car and I have the keys in my hands, and I put the keys on the table when I was grabbing my stuff. So now when I got to the car, I didn't have the keys. So I follow the steps that I did, what I did in the last 5 minutes. Okay, I got my papers, I got the coffee, I got the food, and I left the keys on the table. So I go back and I grab the keys and I get back to the car. That is normal. Now, if I were to get to my car and then suddenly I don't have the keys with me and I stayed right there in front of the car and I blocked out, what did I do in the last 5-10 minutes? And I can't remember if I had the key or where I left the key. That is an issue. Difficulties with things that are familiar to you. If you have a caregiver that comes as well, my grandma, she's been cooking, for Minnesota, tuna casserole for the last 30 years. She does it for every Christmas, for Thanksgiving, for every birthday, and she always cooked it the same way. But suddenly she was cooking this last week and she forgot, the amount of noodles, the amount of meat, how long do you cook this, and how you prepare this. Something she's familiar with. She's been doing it for the last 30 years. And suddenly they forgot. There can be another issue too. People communicate. If somebody sends you an email and then or a text, and then somebody who writes and usually communicates with you, and suddenly the words are not making any sense, or things are not being put together right, and they can be an issue. And when the people I've seen the people that work in the community, because this affects the short-term memory first, and as it progresses, it affects the long-term memory. People will go back to their native language, because the long-term memory is the last thing to go. So therefore, they default to the native language. So Alzheimer's affects 90,000 people in the state of Minnesota today. People 65 years and over is 1 out of 10, and people 83 years and over is 1 out of 3. So it's something really common. It's just a lot of the clinics, especially the clinics that we work, and the federally qualified clinics, they're still not doing a lot of the assessments and the testing necessary for. So it is a really common problem. Another issue, you may have somebody coming into the clinic and then having, today is like Wednesday, and they don't know if it's a Tuesday, Wednesday, or Thursday, or they're overdressed for the weather, and they're just disoriented, and they don't know how they got there or who's picking them up. They can be another sign. And those are just only a few signs. And then the key things that we tell people and we work with people, for example, people in the Latino community. It doesn't mean because somebody has some memory issues that they have an Alzheimer's or dementia, because this can be linked if they have a diabetes and they're not taking care of the diabetes, can cause memory issues. If they have high blood pressure and they're not taking care of it, can cause memory issues. Or if they're taking medications, combinations with some other things, it can also cause memory issues. So when it comes to the diverse populations, we really prepare them when they go to their doctor to ask very specific questions and to take notes, especially the caregiver. This is the changes that I see in my mom or my grandma in the last 6 months. Otherwise, the doctor goes through the motions, and then sometimes they don't look at the brain health, which what's good for your heart is good for your brain because it's a blood related disease. So speaking of that, let me go to the next one. So this is some of the numbers of, like I said, affects the Latino population 1.5% more than the general population, affects the African American population twice as much. So, and the thing is, the services, and that's the reason why we go in the inner cities and trying to go right where those services are, where the populations are, because they're not getting to the people. And so those are some of the numbers and the percentages that I gave you before. And this is, before we go into the questions, this is how you outreach. Can you see the top, in the top of the page, the web page? Yeah, right there. So if you go onto the site, which it has its own site, culturalconsultants.com, it'll be the list of people there, which right now is about 12 people. Most of the people are here in the metro area, but there are people, and when you click in each person and the area they work on, they will tell you where are they willing to go. If they're willing to go anywhere in the state. I know this is for women's health. In my experience working with the ladies, as I work with the chemical dependency of the domestic abuse groups, one of the biggest gaps is not only the language, because after I work with the guys, I will have contacts with the victims. And then a lot of times, because they don't speak English, they don't know how to go and get any help. It can be a shelter 4 blocks away and they won't know it. So a lot of those, the ladies, they will stay in the abusive relationship for a long time because they don't think there is a way out. And because, they're here, with no work and no English and no way to get out. So they truly don't think that they can, make it on their own. Therefore, they will stay with a person because he's the one working, he's the one bringing money, and they're afraid to lose their house. And therefore, if you don't have a apartment, you don't have the rent, and then you lose your kids. So that is the thing. With the biggest gap is the access to healthcare, and either for the domestic groups or the chemical dependency groups, because the people without insurance will mainly depend on the federally qualified clinics. So if you have any questions, I know there was a lot of information at once, but
let's go back to the full screen with him. You want to stop sharing so we can see you a little better? And then we can entertain questions at this point about cultural consultants.
Yeah. I know I jumped from what I do to the groups, but I just want to mainly address and answer the questions about the gaps and what is the difference with the clients that you usually see in the clinics, and then the clients from the diverse communities you may encounter, or how to increase those numbers in the clinic, because the need is definitely there. Mm-hmm. It's just people are now making it to the clinics or to the programs.
Mm-hmm. Yeah, we have, at Wayside, we've worked with some clients who English is not their first language, and sometimes to the point where they don't speak English, and we have an interpreter come in to work with them. And I'm interested in what you said about just translating it to the different language doesn't solve the communication problem. So what are some of the things that we might be aware of, how we talk about chemical dependency specifically, that might not translate well, even if it's being translated into Spanish? What are some of the things that we might say that we might need to communicate differently to really make sense to a client that doesn't speak English?
And those are hard. Like the chemical dependency program that I was doing was the driving of the care, just mainly working with people with DUIs. And then the curriculum was in English, so I translated and I used that base and what I know applies to the people. And a lot of with the chemical dependency, it comes with the cultural traditions, which a lot of times those tradition does not make it. I think, can you guys still see me?
Yep.
and disappear. The tradition does not make it right. Like, drinking and driving, obviously the people that I had in the group, because they didn't speak English, obviously they grew up somewhere else. And then they're obviously learning now the hard way what drinking and driving was not okay here. So it takes a while to break through some of those traditions, just because it is a tradition doesn't make it right. And the hard thing about this, like you said, you use an interpreter. But when you're doing a mental health program or a mental health assessment, a lot of times with interpreting, and depends how good the interpreter is, you lose a lot of those details where they actually tell you what the actual issue is. That's what I did the assessment myself, and I did the follow-up with people myself in Spanish. But yeah, obviously using an interpreter is better than nothing. But yeah, I think it's just the biggest piece of that is breaking through some of those, cultural customs that people had that they bring with them, which doesn't mean, I always tell people, this is who you are, this is where you grew up, this is who you are. But if you want to help people assimilate the culture here locally and to adjust better, that you kind of have to get a mixture. This is how things work in here, still respecting who they are and what they bring with them, but it still help them assimilate, how things and the expectations are, with the norms of, here in Minnesota. So it's kind of finding that balance between respecting that, culture where they're coming from, at the same time, okay, now we're here. And then to help in acculturate, because the problem is people will be here, and because they don't speak English, they will stay within that group for like 10, 15 years. But they still feel that, like, that's the little world. And then after a while, I think that it sets in, like, I've been here this long, and I only move in this, like, the small area. I work here, I go shopping here, and then they tend not to leave the area because there's the comfort zone. And so you don't have to speak English to be able to acculturate and get, familiar just with the general, culture of the, local culture. Because I think that this when it sits, and I've seen people gets really, anxiety and even to, depression, because I think that after a while they realize, I've been living in a bubble for years. So I don't know if it makes sense,
Yeah, and is that something that a cultural consultant could do if someone came to Wayside, sat in some groups, and could give us feedback on maybe some of the ways that we phrase things that isn't going to translate?
Right. In some of those words, like working with the Hmong community, like when we're talking about dementia, there's not the word does not exist in Hmong. So for them to make him understand what that means, yeah, it just goes beyond the translation. It's to, and even with the the Native American people, obviously there's no need for translation, but they don't believe in dementia, more of like the way you come in the world and the way you leave, because that's how your mind starts leaving. And then, you start kind of going back to the early stage. But yeah, those are the biggest pieces. And then, is the trust built with the consultant and the community. I think that makes the biggest difference. So if you have somebody there, and bottom line, I think if people need certain help, they're going to go wherever the help is needed. But when they see a familiar face or somebody that looks like them or somebody that understands the culture and the traditions, most likely they're going to go there for, for services. And I done that, like I said, in places where you go and then they never had, the Hispanic people in there. Doesn't mean they didn't need the services, but then you have to go and outreach and do the education in the community where they are, and they eventually will come to you, because the need is always going to be there, especially for the stuff you guys do. There's definitely, always a need for that. Yeah, with the chemical dependency group, sadly, for like the DUI groups, used to be always a waiting list to do that, the groups. But yeah.
If others have questions too, I want them to jump in. I have lots of questions. One is, what do you hear in the Latino community about opioid use disorder or opioids? What's the talk there? What has been helpful for you as a provider to know about working with that community about that?
Obvious, yeah, and it's funny. They have a thing in the news last night. I don't know if you saw that. Channel 9 had something. It was about the opioids, and because people self-medicating with that, and because now they're looking for all the alternatives and opioids because they're so cheap, like meth and stuff. So it is obviously it's like any other dependency, and within the Latino community, like with those guys that I work with, that even from the beginning, I always look at that as a secondary emotion, like the drinking or the opioids or whatever. So trying to get to the source of the problem, whatever that is, which will eventually get rid of the dependency. But with the opioids, I think it's less than a problem with the Latino community because they don't have as much as the access to to the doctors and to buy, like legally buy the medications. So I think for that, they look for all the alternatives. The problem is more with drinking of the other drugs, but I would say mainly with drinking because it's the only legal drugs. But
Access. Yeah.
yes, it's easier access. And the opioids is not there; it isn't. But they usually, I would say they don't know how to work the system as well as other people to, because it starts with the doctor prescriptions first. So,
Yeah.
But yeah, I know there's a big one now because it seems to be one of the biggest problems. And then, like they had in the news last night saying because of now they're coming across the border and they're becoming so cheap that people has easier access to it.
Yeah.
I mean, it's not an easy answer for that. It's yeah.
I wondered too about, and this is probably something a cultural consultant could help with, is if we're an agency that wants to welcome clients who are, if they're undocumented, if they're immigrants, if they're not sure where to go for healthcare and they're not sure if they can go to treatment if they don't have insurance, how we as an agency can portray our openness to work with clients like that and get back past some of that, like you said, healthy suspicion of what you can and can't say.
Well, as an agency, like any other agencies that I work with, they were trying to target the same population. First, they work with a grant to serve a particular group because they know they're being underserved. And what the grant does obviously helps you to level, because you're going to have so many of those people that, like let's say you do a Spanish program, they're going to be probably about half, they're going to have insurance and you're going to be able to build insurance. But there's going to be another half, they're going to be, it's called pay by patient. So they pay by fee. And so, but the fee is not going to cover the entire cost of the program. So you kind of balance that out and use the grant to serve those people. But the main thing is like gaining the trust of the people, knowing that, it's not that you don't want to connect your program with the government, but that's the thing, they're afraid to share the information if they share the information with somebody else. So, which obviously you won't, because the HIPAA applies to anybody. So make them very clear and very specific that this is private, this is a service, it has nothing to do with insurance, and they can, that you will not share the information with anybody else, just like you would with anybody. But it's just because of the particular population, they're really hesitant because of the whole, atmosphere that we have right now. It takes a while to gain the trust. So having a cultural consultant that knows how to relate to those people and they know how to, because it takes a while, like anybody else, to gain that trust and say, hey, this is service that they're providing here. And then you don't have to worry about it. This is all about the service,
So a cultural consultant could come in and look at our outreach efforts and make sure that they're appropriate if we're going to do outreach, and
right, and tell you where
system,
you're doing the outreach, where and how you're doing the outreach.
Yeah, and then that our systems make sense. If we say we're open to you, but come in and fill out this form, and the form is difficult to fill out and scary, then that's not going to they're not going to continue to come back and see us. Can a cultural consultant look at those things like forms and our marketing or outreach and help us do better?
Right. Well, those marketing forms, like even like with the release of information form, what I did is I took the form and you read the first line and I write a line in Spanish right under that. So people knows where to fill in and what to understand, even if they write it in Spanish. So then you write the next line. So you do one line in English and one in Spanish. So by the time it gets to the person in the front desk, they don't have to read Spanish to understand how the form was filled and what the information is. So, and it doesn't have to be like a long form. The consent is 1 page and the intake form can be 2 pages, but it's just one right line in English, one in Spanish. So that people, even though if they don't know how to read English, they can write, and then the person in there, they don't have to read Spanish in order to, to read the form. So yeah, and then those can be, I done those before for the agencies, right?
Okay.
And especially if people are signing consent, you have to make sure they understand, because a lot of times, the interpreter is going to interpret for you what's being said, but the person is the one signing. So, it is, best practice to know so they can read and understand and know what they're signing. So there is no questions,
That makes sense.
Yeah, the consultants can definitely help with that.
Are there any other questions? Deb, did you have any, or I'm not sure who joined us?
And Deb, she's from the, what part of Hennepin County are you with?
I'm sorry.
Rock.
I didn't hear the question.
Oh,
You
no,
do?
I can see the person up on the top of the screen. She's on the, says Minnesota Hennepin County.
That's Roxanne.
Yeah.
Oh,
Oh, Roxanne, you're muted.
Oh, she's muted.
Oh, she's
I can read her lips. I got it. I got you.
Can you?
You said it all.
Hennepin Healthcare, the HCMC, and we do Project Echo for opioids for the primary care physicians. And I was looking through our cases because I know that we've had a case, middle-aged woman, Hispanic, and I couldn't remember a lot about the details, but I know that there was something that was in regards to her husband, disapproving of her use of the opioids. And I remember the case consultation and that nobody really brought up the fact that she was Hispanic. And I said, I was thinking, because I'm the coordinator, I don't really participate in the consultation, but I was thinking that in part, my understanding is with the kind of concerns, like as you describe, that there may have been a question to ask about, is it okay if we involve your husband in the care? Or, really considering the machismo emphasis and the need for at least understanding her role in relation to her husband and how that might have been handled. And of course, we're talking about physicians that have maybe 10 or 15 minutes with the people. But how can we help without doing consultations from the, cultural consultants, but how can we help the physicians think about, well, that cultural context needs to be considered when you're looking at why she is or is not coming to clinic.
Right.
And it could be, in fact, she doesn't have permission from her husband to come.
Right. And a lot of time, and it's hard for the doctor because, like I said, only had 10, 15 minutes. They had to move along. So the doctor will recognize that. And if he sees there is an issue, to refer to the social worker, because the social worker is the one who's going to be able to a little deeper into that and see if there is any problem or there is a reason why, if it was, an abusive, situation, well, there's the reason why she doesn't want the husband to get in trouble because, he is the provider, and she,
Right.
and when you talk to the people right away, like when I talk to the families, I can tell the ones that are here with insurance, ones are not. So the dynamics are very different there. If they're here without insurance, well, he's the provider. She definitely doesn't want to lose him, so they don't want to involve him because they don't want him to get in trouble. And therefore it goes, like I said, it goes to rent, it goes to house, it goes to apartment, So, and a lot of times is because of the whole macho mentality of he has to be the one that decides. So and it's hard because with some of the ladies that I work, to me, it's really obvious what they need to do, but you still need to empower them to take their own decisions. Because you can help them right there in the office for a few minutes, but they're going to go back home and do what they need to do. They need to be the ones making those calls, making those decisions to and a lot of times even if that means leaving that relation, leaving the situation, but they have to make that, like you giving the tools to empower them to make that call.
All right. And what we're often trying to do is to help rural primary care physicians or, and some of these folks do have teams. Like on our team here, we have an RN, we have a social worker, we have an LADC, things of that sort. But I think the thing is, how do we help narrow in the attention for the prescribing or the real issues related to the doc to say, okay, culturally, have you considered that one of the limitations is that she needs to be asked about the relationship with her husband? And that can then lead to what she wants next. And then if there's a disconnect with what he and she want, then how do you empower that? Is that part of what I'm hearing? To help the docs? I mean, yes, the social worker or the LADC can take more time, but
Right.
if we're trying to help, maybe those people that are out in a rural community in
And those
Minnesota.
are hard because, and there is a lot. I mean, I was on the Mexican consulate this morning, and because it's the only consulate in the state of Minnesota, people coming from like 3 or 4 hours away from here. And those are people who live in a farm in the middle of nowhere because, they work the farm year round.
Right.
So, you talking about dependent, they truly depend on their husband. So and you have to understand the dynamic because, not only she doesn't speak English, she doesn't know where to go, but there's nowhere to go, So, and it's a tough situation because you want to, besides the dependency or whatever, you're trying to get to the real, on this, what I've said, the social worker comes into place, the real need or what's the, because when people are trying to survive, they're not worry about their chemical dependency or those issues. They're just trying to survive. So you need to go to the lower base to where housing, or even the tools that she needs to get out of the situation. So especially when you're way out there. And I know in HCMC, I know they got a lot of resources. They see a lot of people there because I've been there. They got and I know they have staff that speak Spanish in there too. So. But those rural things, because I know there's, think about they came into the Minnesota, into the country to work in the particular farm. So that's it. That's, this little world. So, it's not an easy answer for that either. But I just, most of the times I'm trying to get to the actual need, which is, goes beyond the dependency and how to get her out of the situation. So.
All right, great. I do want to check in with the two folks who are with us on the phone.
And we got to the last page for the we did get to the last page.
We did.
The website and the information, because there, like I said, once you go on there and click, it has the profile for everybody who's a cultural consultant and the people from the Somali and the Hmong community, which they do a lot of work too. So, and there's 2 from the Hispanic community as well.
Okay. Deb Morrison, did you have any questions? Deb? Looks like you unmuted.
Oh, can you hear me?
Now I can.
Oh, okay. I was wondering if I could get a copy of the slides or the presentation since I wasn't able to see it.
And the slide, the presentation is, if you go to the very last page, when it has the website for the cultural consultant site, all the information that you see and more is there.
So I will agree. I'm going to send out all of Alejandro's slides along with an evaluation and a couple of other handouts that we got from the Cultural Consultants Organization. And I'll include that all to everyone who's on the call today.
Yeah.
So you'll get those for sure, Deb.
Thank you.
And Rebecca, I know we were trying to crunch a lot of information in 20 minutes. So, I know I was going really fast, and I was talking about the dementia and Alzheimer's because that is how this group initially through the Minnesota Board on Aging got together, but then it grew into people working as a cultural consultant for the other, expertise that they have in the area for each, from each group. So I know I threw a lot of information out there, but, they can either look in the site or feel free to contact me if there's anything in particular they need to know.
Okay.
I just want to be a little more efficient.
Let me ask one more question. Is there a person, I don't know if it's a woman or not, who's calling us from 651-431-2465?
Oh, I see that one.
Do you see that one? Who is that?
Rebecca, this is Ruthie.
Oh, yay. Hi, Ruthie.
Hi. I thought you would recognize my number, but you call me sometime on other numbers.
Yeah. Well, thanks for joining us. Did you have any questions for Alejandro?
No, I do not. And I missed the first part of his talk, so I'm just sort of listening.
All
Well,
right,
so,
wonderful.
Rebecca, I think if you share the site, I mean, all the information is in there in the site.
Okay.
So
We'll get everything to
that's the
you.
main thing. The last page.
Mm-hmm.
Yeah.
Well, if there
Thank
aren't
you.
You're welcome. If there aren't any more questions, I want to remind people, I'm going to kind of wrap us up so that we can get on with our day, but I want to let you know that next time we meet will be November 15th, and our group coming in to share information with us is the Minnesota Recovery Connection. And then we've got a great lineup coming up in December and January. We've got Ramsey County Mothers First. We will not have an echo session on the 20th of December. And then in January, Out Front, Minnesota. And January 17th, No Wrong Door out of Hennepin County. So lots of good information, and please share your ideas with us. If you can think of things that either people who should be joining us or topics that we should be covering, feel free to email me or Lucia. She's the one who sent the invitations, and we will do our best to recruit a specialist or an expert to talk and speak to those issues. Before we finish, any other questions or business we should consider?
No, just thank you for Alejandro. This was great. Great
Yeah.
information.
Well, thank you. I hope
so
it was
much.
helpful a little bit. I know it was really crunch quick last minute, but yes.
Mhm.
And for you guys there in the Wayside Recovery Center, Rebecca, I'll email you information if you can share it. But I know she's the director of clinical services
Mhm.
about some of the assessments that we do. If you do need assessments done, either for the chemical dependency or for the risk assessments.
Yeah,
So
wonderful.
for the program that we do, and I can elaborate a little more on that about the domestic programs that we do.
Wonderful. Thank
So-
you so much, everyone. Have a wonderful day. Enjoy the sunshine. It sounds like it's going to get
Yes.
gloomy. So go
Nice
go
out.
see it while it's here.
Yeah.
Thank you, everyone.
All right. Nice meeting you guys. Thank you. Bye.